Topic for today's presentation, guest lecture would be Veneering Teeth with porcelain. You all might be aware of the topic from the website of the 49th IPS. To begin with, a couple of quotes. All human desires are in some way related to beauty, and beauty is the illumination of smile, and smile is something that we work upon day in, day. I bring warm regards from the Annapaya University and the Annapaya Dental College at Mangalore. And my goal for today is to inspire and to be inspired. How and why are concepts changing today? How does failure occur? What are the various materials that we have? What are the different preparation designs? What have we learned from the previous generation of materials and techniques? What are some of the variables that affect the outcomes? We'll try to decipher all these things. Now, in the past, the achievement of either aesthetics or function required the sacrifice of the other. Whenever function was the predominant requirement, aesthetics had to be compromised. Today's materials and treatment approaches permit us to achieve both these goals simultaneously. Now, why porcelain veneers? Preparing a tooth for a crown typically involves removal of 63 to 76% of the structure of the tooth. We should all be aware that the tooth inside has a big void in the form of a pulp cavity. So when we prepare all around the tooth, close to 76% of the tooth structure is removed. Whereas with a porcelain veneer, from the minimalistic preparations to the maximum preparations, it is around 3 to 30%. So we can say even a maximum preparation of the porcelain for porcelain veneers would be half the amount of tooth structure that is lost during the tooth preparation. So it is highly, what we can say, conservative type of preparation. The way the porcelain veneers handle light is similar to natural teeth, giving a tooth-like appearance. A porcelain veneer surface resists wear as well as staining, creating a very durable surface for us. Now, classification of porcelain veneers. There are innumerable types of classifications in different textbooks, in different aesthetic dentistry books, in different articles. But I would pick up this classification, which is based on indications. Type 1 is whitening resistant teeth. We need to understand that if the problem of the patient is only with the color of the tooth, then we should always be doing bleaching or tooth whitening. But when there is a deep-seated stain like the tetracycline stains or something like that, and which we feel would not be whitened by whitening procedures, then a laminate comes into the picture or a veneer comes into the picture. So those could be put under the type 1, and the type 2 would be some important morphological changes to be brought in to the patient's dentition, and type 3, mild malpositions of the tooth or teeth, which would warrant otherwise an orthodontic correction and which might take a prolonged period of time, and the patient needs an immediate aesthetic result. Now, when should we not do porcelain veneers? Lack of adequate marginal and internal enamel, unrealistic patients' expectations, unresolved functional issues. If we don't do this, then most of the time the laminates would fail. When orthodontics or bleaching is the right choice, as I just mentioned. Now, who are the ideal patients for porcelain veneers? An optimal static and a dynamic occlusal relationship is of prime importance in the patients receiving veneers. Since the usual mode of failure is the fracture at the incisal edges, the incisal tips should be placed in such a manner that they do not contact the opposing dentition. As any other restoration, a healthy periodontium forms a sound foundation on which the restoration should rest. Mouth breathers are considered as poor candidates, again due to persistent gingivitis in them. Now, looking at these pictures, should we be doing veneers for these cases? I would say a big no. In the first picture, it is orthodontics. We cannot think about doing veneers and correcting such a malposition of the teeth. In the second picture, it is very evident that there is some reason for severe tooth loss. So we need to treat the tooth loss and assess the cost before we even think about doing something to his dentition. Now, in the third, we can all see that there is a severe loss of enamel in the cervical region especially, and this could always jeopardize the bonding of our laminates. And in the fourth picture, it is definitely a case for doing a whitening procedure like bleaching and not to do laminates. Now, what are the important guidelines? Most conservative of the veneer preparation is 0.3 millimeters, a minimum of 0.2 mm of additional preparation required for each vita shade change. That means you need to prepare 0.2 mm of additional tooth surface if you want to change the shade of the patient. Now, this picture depicts like if you want to move the shade from A4 to A1, we need to do a total of 0.9 mm of tooth preparation. Otherwise, you would not be able to achieve that kind of shade change. Now, if you want to change the shade from A2 to A1, that is by one shade you want to whiten, then we need to prepare 0.5 mm. And if we are doing laminates or veneers only for morphologic change corrections, then the shade won't be an issue. If it is A1 to A1, then only a 0.3 mm of preparation would suffice. And then a maximum of 1.5 mm unsupported porcelain is acceptable. Anything more than that, it could be a case where you can have a fractured porcelain restoration, especially when we are using feldspathic porcelain or lithium disilicate as our veneering material. Even a huge diastema proximally or a huge incisal edge elevation of more than 1.5 millimeters, we need to think twice before doing that. Now, the patient's age, sex, and personality. This is something which we need to consider when we do any restorative or prosthodontic change in a patient's mouth. So it is imperative that we look in and guide the technician along with taking suggestions from the patient regarding how the patient's teeth should look for that particular age, for that particular personality, and of course for that particular sex. It is very imperative that we look into this matter so that we don't provide veneers which look out of place in that particular individual. And of course, golden proportion comes into the picture when we are trying to close some multiple diastemas, or also when we are trying to do morphologic changes for the tooth. So we need to make sure that we maintain this proportion of 1:1.68 in such a way that the size of the tooth, the disparity in the size of the tooth or teeth between central, lateral, and canine would bring about a major aesthetic change. Another thing that we need to look into is the margin placement. Smile line plays a huge role in margin placement. Now, margin placement is, you can see in the first picture, the patient has a gummy smile. That means the entire gingiva is visible. So in this case, we have to hide the margins of the veneer. And when you have to hide the margins of the veneer, we need to go slightly subgingival. So whereas in the second picture, you can see that the patient has a tooth papilla smile. Only the papilla is visible. So you can get away maybe with a equigingival kind of margin. And in the third picture, as you can see, it's a tooth smile, and then there's no gingiva is exposed, not even the papilla is exposed. In such a scenario, we have no business going closer to the gingiva. So we need to be supragingival. Now, another thing that we need to look at, this would be an issue only in a patient who has a gummy smile. So if the patient has a toothy smile, then the gingival exposure is not there, so we don't need to bother about this. But when the patient has a gummy smile or a tooth papilla smile, we need to bother about the gingival zenith. We all are aware that irregular or non-uniform gingival zeniths are not aesthetic. And also we need to understand that the zenith of the gingiva is not in the center of the tooth, as you can see in the picture. It is slightly off-center towards the distal, and this off-center or this angulation of the gingival zenith towards the distal increases from central to lateral to canine. Now, in case you need to do a change in the gingival zenith, we can always use a laser gingivectomy procedure to alter the gingival zenith and move the gingival zenith apically, and also maybe move the gingival zenith distally to achieve a symmetrical gingival zenith and then restore the patient. Now, in this patient had a diastema, a slight overlap of 1:1. So, and also you can see that this patient has an uneven gingival zenith, especially the lateral incisors and the canines on one side. Now, to top it all, this patient also had a gummy smile. Now, first we did a scan of her cast, and then we saw how whether the golden proportion can be met and how much the width of the tooth increases. The scan was shared with the patient, and the patient gave a thumbs up to the size of the teeth and alignment, and then we go ahead and then corrected the patient like this. So first, our periodontist friends came into the picture and they improved the gingival zenith contour, and then of course the laminates were fabricated, and the improvement in the patient's smile was very obvious. Now, going into the shade selection, select the shade of the restoration before you prep, in case you need to match the shade to the adjacent teeth. Now, if you're doing all the anterior teeth, then there is no question of matching with any other tooth, because you're looking at changing the shade maybe. So in such a case, the shade matching should not be an issue. But if you're doing isolated tooth or one or two teeth in the anterior segment, of course, you need to match it with the neighboring teeth. Now, what are the do's and don'ts for shade selection? Tooth color has an intimate relationship with the color of the eyes, skin, as well as both these elements have the same embryonic origin and should be considered in shade selection. Instead of precisely matching the shade, a shade of lower chroma and a higher value can be selected. Now, why do you need to do that? This provides the dentist some leeway and allows for slight darkening attributable to increased translucency, which happens with the polymerization of the composite loading cement. So shade selection should be done at the beginning of the appointment to avoid vision fatigue. Clinical tips for veneer shade selection. Establish a properly lighted environment for shade selection. Select the final shade of the veneers based upon the patient's preference, as well as the tone of the eyes and the skin. Take a photograph of the selected shade type adjacent to the unprepared tooth like this. Now, in this case, we wanted to do a veneer on 1-1, so we needed to match it with the 1-2. So we take the picture of the shade guide adjacent to 1-2. Select the original shade of the hydrated, unprepared tooth. Before you start preparation, you take the shade of the tooth to be veneer, and then select the stump shade after the final tooth preparation and take a photograph. That is very important because the stump shade is critical for the technician, because in case it's a very dark stump, the technician needs to know how much he needs to use opacers to mask this effect of the dark stump shade. Now, how do you select stump shade? Stump shade can be selected using a shade guide, which is the most popular among these shade guides. It's by the Ivoclar Viewer Dent. You can use the stump shade like this. So you can provide the information to the technician, the tooth shade, stump shade, and the desired shade. Now, in case cases like this, where post preparation is extremely dark, and whatever you do, you would not be able to mask this darkness with your veneer, then you can use opaque veneer materials like zirconia based or lucite based, which have less glassy content and more crystalline content. Now, what are the different materials that are available for us to choose from for the veneers? We all are very aware of feldspathic porcelain, and the most aesthetic among all the porcelains is the feldspathic porcelain, but we know that it is the least as far as mechanical properties and strength is concerned. So feldspathic porcelain have been used for many years as laminate or veneer material, but they are less comfortable as far as their mechanical properties are concerned. So reinforcing of this kind of feldspathic porcelain has happened by addition of lithium disilicate or lucite reinforced, and that increases the strength quite significantly of the material. And of course, these are also highly aesthetic and translucent, but may not be at the level of feldspathic porcelain, but still they are sufficient to provide a good aesthetic makeover. Nowadays, we have high translucent zirconia, monolithic zirconia, which are very translucent. And these can also be used for fabrication of laminate veneers. All the companies have this. This does not have a glassy face, so bonding this kind of laminates is a little tricky, and they are least translucent, but of course, they can be used for aesthetic purposes of smile makeover. Now, two major principles governing the tooth preparation. Preparation must be conservative. Retention is slowly by addition rather than by tooth preparation design. Now, what are the different types? The type 1, also called as the contact lens type of preparation. It's also called window preparation. It's also called the facial only preparation, where we prepare only the labial surface. We don't touch anything else. Now, type 2, it's same as the contact lens of the type 1, but here the incisal edge is also prepared. So this is also called as the classical or the conventional preparation, or the incisal butt preparation. Now, then there is a type 3, which is called a lingual wrap or the palatal wrap type of preparation, which is almost similar to that of a full coverage preparation, which indicative for extensive color change and of course contour alterations. Now, how to handle the incisal edge? If you use a type 1, the laminates go and sit with no path of insertion. And then if you use the type 2, that is the incisal butt, there is a path of insertion. So trial of the laminates becomes easy. You can assess the fit of the laminate a little better. Whereas in the type 3 type of laminates, you cannot have any undercuts in your preparation, because there will be a path of insertion, and the path of insertion is a restricted path of insertion. So if there are any undercuts in your preparation and you try to seat the laminate veneers, which are very fragile, the veneers could always fracture. So the preparation of the lingual wrap, quality of preparation should be optimum for you to be able to seat these laminates. So what are the armamentarium that can be used? Depth cutter of around 1 mm. So a 1 mm depth cutter would provide a depth cuts of 0.5 mm, half, and a 0.6 mm depth cutter would provide a depth of preparation of 0.3 millimeters. That's again half. Of course, a round burr is required, a round-ended tapering diamond is required, and finishing diamonds are also. Now, going into the tooth preparation, facial reduction, since the amount of enamel decreases at the cement to enamel junction, it is imperative that we reduce slightly lesser at the cervical third and more in the middle third and the incisal third, maybe a maximum in the incisal third. So these are the depth cutting burrs, and of course we can't do a monoplane reduction in the anterior segment. The tooth definitely has biplanar facial surface, so we need to reduce the cervical area like this, and then the middle third areas and the incisal areas, as you can see in the pictures. We also have depth cutting diamonds which have progressively greater dimensions, so that you end up reducing the least in the cervical third, on an average in the middle third, and the maximum in the incisal third, where we expect the enamel to be in the highest quantum. Now, the most conservative among all the preparation, the facial veneer preparation, we reduce only the labial aspect. So I'm going to project to you pictures of phantomite preparation as well as a clinical case. So here we are placing a depth cut in the middle third, the clinical case where the depth cut is placed in the middle third, then the depth cuts in the cervical third, with the clinical case, then the depth cut in the incisal third. And this is the clinical case, and we can see the depth cuts here, nice and deep, and according to the depth that we desire. Just by naked eye, you want to prepare without placing these depth cuts, you would always end up over preparing or under preparing. Now then, once the depth cuts are ready, you need to merge the tooth preparation using a tapered diamond with a rounded end at the tip to achieve a mini chamfer kind of a margin. So you can even mark the depth of the depth cuts with the pencil or a felt pen, and then go on reducing until these marks slowly fade away. So this is the final preparation in the phantom head, final preparation in the mouth. Both the centrals have been prepared. And one thing I want you to know, as you can see in this case, laminates have been prepared, but the clinician has forgotten or not been able to mask the proximal line angles with this preparation. So it is imperative that we take the proximal line angles as deep into the proximal surface as possible, so that the margins of your restoration is not exposed, as is in this case. Now, the incisal bud preparation is quite similar to the facial only preparation, where we reduce the incisal edge by 1 to 1.5 millimeters, whatever is your desired depth. I wouldn't prefer to prepare more than 1.5 mm, because I don't want more than 1.5 mm of unsupported porcelain at the incisal edge. So it is imperative that you bevel the bevel so that there are no stress concentrations, and this is the final preparation. Now, the lingual wrap preparation, I don't usually prefer this kind of design. One, the complexity of the preparation. Another is that the path of insertion is quite limited in this, so fractures of the porcelain is also quite common. Now, this is how you do it. We do a two-plane reduction, and then the incisal edge around 1.5 to 2 mm. Now, when do we do this lingual wrap? Now, if you're not doing it regularly, then when do we do it? When an existing restoration around the incisal edge is onto the lingual side of the incisal edge, where are defects on the lingual surface is there. And of course, multiple diastemas, as you can see in the picture that is projected, and less than ideal enamel remaining. So when there is less than ideal enamel remaining, we should always know that the bonding is slightly compromised. So we need a little bit of more retention. By wrapping around the lingual side, we end up getting this more retention. And of course, the previous veneers were wrapped. Now, the lingual reduction for a lingual wrap, lingual finish line is created by a round-ended tapered diamond, and you prepare around 0.5 millimeters. So this is how on the phantom head preparation. And then the depth cuts for the canine, we did this preparation because the canine, we had to give a canine guided occlusion, so we gave a lingual wrap kind of a preparation there. Now, the looking at rationale of tooth preparation for certain cases, now to achieve sufficient and even space for a future restoration, especially when we want to do morphological changes and correct malpositions of the teeth. So in such a case, the tooth preparation should be carried out by pre-operatively designing the restoration and by referring to targeted restorative space, TRS. Remember this word, targeted restorative space. Now, I'll just explain to you what it is. Now, in case you want to do a morphologic change to a tooth, or you want to do a correction of the malposition of the tooth, what you do is you mock up using a wax, and then you do temporization on the tooth, and then you start preparing from over that. So the targeted restorative space would bring about only that much of reduction of the tooth as is necessary, rather than unnecessary over preparation of the tooth. Just discuss a case related to the same. So this patient has an unaesthetic smile, of course a reverse smile, and you can see the canines being at a lower level than the centrals. The intraoral pictures are the same. Lots of composite restorations on the labial surface. What we did a mock-up wax mock-up, then we took a putty index, and then we extruded the temporary resin material onto the putty index, placed it in the patient's mouth, unprepared teeth, and then we achieved something like this. So this was with the temporaries in the mouth. No preparation is done on the patient's in the patient's mouth yet. And this picture on this is shown to the patient, and we assess the smile line and then take the acceptance of the smile from the patient, and everybody is happy, patient is happy, we are happy, dentist is happy. And now we know that this is going to be the final outcome of the preparation, outcome of the veneers. So we want to do preparation through these temporaries, because we want to achieve a laminate bulk of 0.3 millimeters. We don't want anything more than that. So we put depth cuts over the temporaries like this. Then you prepare over the temporaries with the burr, and then we achieve the targeted restorative space, as you can see in the picture on the right with the putty index. We are not over prepared. And this is the outcome of the case finally with the finished veneers placed, permanent veneers placed. Now, once the preparation is done, this is something, IDS is something which I always advocate. Immediate dentin sealing is a must, especially when you have exposure of the dentin. There's no need to do any sealing if you are completely or totally in enamel in the entire tooth surface. If you are in dentin, you need to do immediate dentin sealing. What are the benefits? Reduced dentin hypersensitivity, and of course, pre-curing bonding agent improves the bond strength, final bond strength, and it also prevents collagen collapse within the dentinal tubules during impression making procedure, and that is critical for us. Now, what do we use to do this dentin sealing? Of course, we use self-etch dentin bonding agents. Self-etch dentin bonding agents, and this table shows, this is from Magna et al. In Journal of JPD 2005, says that the immediate dentin sealing group has got 5 times more tensile bond strength in comparison to the delayed dentin sealing group. Now, temporization. Some clinicians say do not place temporaries. Now, they have some reason for that. Now, what are the reasons? Temporaries could create some degree of gum inflammation, as you can't floss around it and clean around the temporary veneer thoroughly. Inflamed gums could be hazardous for bonding. When there is inflamed gums, there is going to be seepage, and then you can't bond the laminates. So it is imperative that you meticulously finish the temporaries in the mouth so that the gingiva remains healthy. On the other hand, the ultimate goal of the provisionals is to master the function and aesthetics of the final restorations. Provisionalization is a practical means of obtaining feedback on the aesthetic parameters from not only the patients, but the dentist and the technician as well. The closer the temporaries are to the desired results, less surprises will be incurred on the day of the delivery. The incisal position can be tested with the provisional restorations that have been fabricated from a diagnostic wax-up. Provisionals also help assess phonetics and function. Now, how do you make the provisions? You have a diagnostic wax-up, and then you have a putty index. Extrude the resin material solely into the putty index, push it back in the mouth in the right position, hold it till the resin sets. And then once it sets, most of the times once it sets, the putty index comes off and the temporaries remain in the mouth as they get caught in the undercuts. So you don't have to tug it out and remove it and reclose it. You can just leave it there and finish it in the mouth. You don't have to remove these temporaries to loot. So we know that it is going to stay there by itself. So finish them. And these are the finished provisionals. Make sure that margins are thoroughly finished so that it heals well. And finally, it heals well. Now, this is a case where the resin material is not completely flown into all the areas necessary. So in one there is a deficiency, and also the temporaries came with the putty index. So we place it back in the patient's mouth. In this case, if we want to loot these temporaries, we need to do a spot etching in the center. Only one spot is etched, and then we extrude some kind of luting resin, or we can even use flowable composites of the desired shade, and then seat the temporary veneers back in the mouth like this, and wipe off the excess, and then light cure them, and then of course finish them. And this is how the temporaries are secure in the mouth. Now the impressions are done, and then the impressions are sent to the laboratory with a lab prescription showing the details of the veneers to be fabricated with the clinical intraoral pictures too. The lab pictures should include the unprepared tooth shade, that's very critical, the stump shade, as I've already mentioned, the desired shade, which shade you want the veneers to be, the laminate veneer material of choice that you have, you don't leave it to the technicians, putty index of the diagnostic wax-up or the temporization, whether the intaglio surface of the laminate or the veneer has to be etched or not. Now, removal of the temporaries. So once the patient comes back for trial of the final veneers, we need to remove the temporaries. So when you have to remove the temporaries, you place strategic cuts right in the center of the veneers, and then you can wrench it out and remove it. And once you remove it, if we have done a spot etching, then it is imperative that you do a finishing of the prepared tooth surface to remove these bonding materials. Try-in and the preparatory steps. The restoration must first be checked on the original stone dies. If you're happy with the fit of the veneers on the stone die, then it goes into the mouth. Individually, one by one, each veneer is tried in the mouth. Then most of the misfits are a result of remnants of the provisional luting cement, so not because of any issues with the laboratory. So you make sure that there are no remnants of the provisional luting cement. All restorations are then placed in toto altogether. If there are multiple veneers to be luted, checked for the proximal contacts and fits. And if you're happy with all, then this is how we do it. These are the clinical case. Try-in is done individually. Then also we can use try-in pastes. If you're using laminates which are having high translucency, the shade of your veneer cement makes a lot of difference. So along with the veneer cement kit, the entire kit, they would also provide you with the try-in paste. So you can use these try-in paste. They help us to check the fit also much easily, because the laminates stay put in the mouth much better because of these try-in pastes. And of course, we can change the shades of the try-in pastes in such a way that you achieve the desired shade of the veneer, and then finally you use a corresponding cement of the try-in paste to lute the veneer, so that you don't have surprises related to the shade of the veneers. Now, one thing you have to understand, that try-in paste should be thoroughly cleansed using resin solvents like acetone or ethanol. If you don't do that, then you might have poor bonding of the laminate with the tooth structure. Now, in this case, as you can see, the light opaque veneer cement, and trial paste, and of course the other lighter trial paste would be giving a different shades to the tooth with the veneer in place. So you got to select which cement you're going to use corresponding to the try-in paste that you have used. Now, once the trial is satisfactory, cementation of the veneer. Now, this is the process for the cementation of the veneers. We need to etch the veneer surface, we need to silanize the veneer surface, then bonding agent, and of course the luting cement. So these are things that are done on the veneer side. And on the tooth side, again, we need to etch the tooth side, and of course prime and bond the tooth side too. Now, on the laminate intaglio surface, how do you do etching and salinization? There are a lot of questions related to etching of the ceramic laminates, because we have different materials now. We are more commonly using the lithium disilicate materials than the feldspathic porcelain veneers. So what is the optimal etching time? How long we need to etch? Is there an optimal concentration of the hydrofluoric acid? Can porcelain be over-etched like the tooth? How do you handle the white residue that is present on the etched surface of the porcelain laminate? So these are the questions that we are going to answer. Now, the studies have shown that if you are using a lithium disilicate veneer, 5% is the right concentration of hydrofluoric acid, and etching time of 20 seconds. That's it. After 20 seconds, we need to wash it off. So once we wash it off, we can see a white residue kind of a thing, as you can see in the picture there. Now, this white residue is like a dirt. You cannot leave it there. We need to remove this white residue to achieve optimum bonding. This is something which is forgotten, not handled well most of the times. So how do you clean the surface? Continuous brushing with the phosphoric acid, our regular 37% phosphoric acid for 1 minute would clean this white residue completely. And once you have done that, you can put it in an ultrasonic bath with distilled water for 1 to 2 minutes to completely clean the laminate, and the laminate is ready. Make sure that during all this process, your fingers don't touch the intaglio surface of the laminate, so that you don't contaminate the laminate. Now, each hydrofluoric acid conditioning needed for all the ceramics, for lithium disilicate and feldspathic porcelain, a big yes. Highly crystalline ceramics like lucite based and zirconia based, no. Now, what is silanization? Coupling agent. It is chemically bonds to the ceramic, makes the ceramic surface hydrophilic, very, very important, so that the bond, the adhesive can easily get into the roughness created by the etchant. Applied to the internal etched surface. After a minute, the silant to be dried with warm hair dryer, which is found to double the bonding effect. I repeat, the silant to be dried with warm hair dryer to double the bonding effect. Another point that you need to understand is these silants which are supplied to us as ceramic primers. If they are present supplied to us in one bottle, then it is most of the time these contents of this one bottle is very, very volatile, and we lose the important contents in the bottle to because of its volatility. So I would always recommend to buy a dual component silant, so that you mix at the time of use and then apply it on the laminates. Silence, also called as ceramic, contain 90% volatile components and need to be airtight. Salinization of highly crystalline, less glassy ceramics like zirconia is questionable again and may be ineffective. Now, to maximize the efficiency of silane, don't let the silane pool. So don't put too much silane. Excessive application of silane creates an unnecessary weak layer. Clinically, the surface of the porcelain should not look shiny after silane application and drying. Once the silane is dried out, the choice of adhesive is applied over the whole interior surface. However, it should be light cured at this stage but kept in the dark. You should not be light cured at this stage and should be kept in the dark. Now, on the prepared tooth surface, once the laminate preparation is done, the tooth is cleaned with pumice, then etched with 37% phosphoric acid for 30 to 40 seconds. No, don't etch any exposed dentin. We don't want to put phosphoric acid on exposed dentin. On the exposed dentin, we need to only apply self-etching, self-priming adhesives. That would suffice. We don't need to etch the exposed dentin. So light curing of adhesives on both the tooth and the laminate should be avoided at this juncture. And so you need to keep the clinical lighting of your clinic to be as low as possible so that they don't get cured. Now, the choice of the luting cement, dual cure cements are mistakenly preferred for laminate luting, but light cured cements are far better than dual cured cements. And the reason being, these dual cured cements have color instability due to amine degradation. So you might have a surprise later on after luting the laminates with dual cure that the color has changed. Sufficient working time is of great utility when luting multiple laminates. We all face this. If you're using dual cure laminates, when we have to lute 6 laminates at one shot, then you need more working time. To prevent any undercuring of the light cured luting cements. Now, if you feel the light cured luting cements may not get cured, extended curing should be exercised. Now, once that is done, dispense the veneer cement onto the intaglio surface of the laminate. Seat the laminate from the incisal to the cervical. Use a brush wetted with adhesive to remove the excess cement. What are the factors responsible for incomplete seating? Premature curing of the adhesive, a cured fragment inside the luting cement, neighboring laminate not seated perfectly. Now you need to understand that all these problems are reversible when light curing cements are used. If you use dual curing cements, the laminate would get bonded due to curing of this thing, and then you may have to remove the laminate by sectioning it. Now, if you're using a light curing cement, any of these misfits, you can always take care and make sure that everything is fine, and then just apply light and it gets cured. And then, of course, finishing of the laminates is critical. The margins can be finished like this, and the final outcome of the laminates very pleasing. This is another case where multiple diastemas and, of course, morphologic changes also we have achieved. Now, how do you bond zirconia veneers? I spoke about zirconia veneers, the present day better. Now, we don't do HF or silanization for zirconia veneers, sandblasting with aluminum oxide to create roughness. Wipe the intaglio surface of the laminate with 5% sodium hypochlorite to clean and activate all the oxides on the surface of both of the phosphates. Application of primers containing 10 MDP is critical for us. Phosphate monomers are very effective in improving cohesive zirconia bonding to resin cements. So 10 MDP containing primers need to be used if you want to bond zirconia veneers to the tooth surface. And of course, because zirconia veneers do not transmit light easily, dual curing resin cements to be used. So these are a couple of cases which I have treated using zirconia laminates. They do reasonably well. Only thing is we would not be able to get the high incisal translucency with these kind of veneers. Now, what could be the reasons for failure of laminates? 3 most common reasons for failures. 31% failed aesthetics. That's what the patients are not happy with the veneer. 31% again structural complications, chips, cracks, etc. And only 13% loss of retention. So we all have a phobia thinking that veneers debond, so we end up doing crowns. No, debonding of veneers is the least among all the failures. Now, what are the porcelain veneer alternatives that we have? Teeth whitening treatments, we are aware, microabrasion technique, orthodontic treatment, aesthetic tooth recontouring, dental bonding, and composite veneers. Now, to conclude, tissue preparation is critical. Diagnostic models for achieving the targeted restorative space, appropriate preparation and of quantity and quality to the preparation accurately, minimalistic approach, treatment feasible, predictable, and repeatable, supragingival and equigingival margins, 0.3 to 0.5 mm chamfer margins, immediate dentin sealing to reduce post-operative complications like sensitivity. Every journey begins with the first step. An objective without a plan is a dream for us. So we cannot just dream, we need to plan adequately to make sure that we satisfy the objective of doing a right smile correction. Happy patients is what we are finally working for. Thank you.